Shukran, Ustad Rad. Okay, so our talk today is about imaging of spondyloarthropathy, all the inflammatory conditions that can affect the spine and the sacroiliac joint. And this is a very important topic because we do see these patients with inflammatory changes involving the spine and sacroiliac joints, and sometimes these patients can be missed. And the reason why they can be missed is because of the great overlap, sometimes in the imaging features between spondyloarthropathy, degenerative disease of the spine, and diffuse idiopathic skeletal hyperostosis. So this is the reason why I give this talk, is really just to familiarize radiologists with the imaging features of the spine and sacroiliac joints and how to differentiate these changes, so that we don't miss these patients, because the um, the emphasis here is on early diagnosis, and the earlier the diagnosis, the better the outcome, because these inflammatory conditions of the spine can be quite disabling and debilitating to the patients. So the early that we detect the disease, the better, because these patients will benefit from a rheumatology consultation and anti-inflammatory treatments such as biologics and disease-modifying drugs. So our talk will focus on understanding different types of spondyloarthropathy entities. We will just cover all these entities and how they look like on imaging. We will also cover some of the imaging tests that can be utilized for detecting all these inflammatory changes in the spine. The major imaging test, obviously, is going to be the MRI scan, and the MRI technique will go over the sequences that we use for imaging these patients. We'll also cover all the imaging features for each and different entity of spondyloarthropathy. And also we will look at the mimickers, SPA. So SPA, I will use the term SPA throughout the talk, and SPA is just a short term for abbreviation for spondyloarthropathy. So we'll look at SPA mimickers as well, because that's the most important part of this talk, is how we can differentiate between SPA and SPA mimickers. So the different entities that we will be talking about would include ankylosing spondylitis, obviously, is the prototype of spondyloarthropathy, and this is the major group of patients with inflammatory changes in the spine. The other group of patients include patients with inflammatory bowel disease, and how this could actually affect the spine and the sacroiliac joints, psoriasis and arthritis. So these are the four groups of inflammatory conditions that we will be talking about in this talk. So how do we approach these patients? So these patients normally referred to us by the rheumatologist, sometimes by internal medicine, and sometimes even by the general practitioners. These patients will normally present with back pain, and the back pain is described as inflammatory back pain rather than degenerate back pain or traumatic back pain or disc-related back pain. So normally in our practice, we would only take referrals from rheumatologists, because rheumatologists would be able to differentiate between what is inflammatory back pain and what is not inflammatory back pain. Because at the end of the day, we don't want to do imaging on patients who may have other causes for back pain rather than inflammatory back pain. The MRI protocol obviously will be very different. So the MRI protocol we use for degenerate spine or for traumatic spine is very different to the MRI protocol we use for spondyloarthropathy. So that's why in our practice, we take referrals from the rheumatologist for inflammatory back pain patients. We normally start these patients with radiographs. We would do imaging of the spine and the sacroiliac joints. Sometimes we may have radiographs of the appendicular skeleton, and if we have radiographs of the appendicular skeleton would be helpful to look at the pattern of disease involvement of the joints. It can be supportive sometimes, particularly in patients where the radiographs may not be quite helpful, especially in the early stages of the disease, or if there is overlap between spondyloarthropathy and degenerate disease of the spine. Then we move on to MRI, and we use the MRI, the spondyloarthropathy MRI protocol, which I will show you in a minute. CT is not always used. We only use CT if there are contraindications for MRI, and also if we were not sure on MRI about the erosions of the articular surfaces, then we would resort to the CT scan. CT also is helpful for detecting enthesophytes and also advanced stages of the disease when there is osseous effusion of the sacroiliac joints. So we'll begin with the MRI. MRI is considered the mainstay for assessing active SPA, and I emphasize the word active because at the end of the day, what the rheumatologists are interested in these patients is the disease activity rather than the chronic changes. They don't necessarily treat chronic changes that we detect on the MRI. They only treat patients if the disease is active on MRI. And we'll see what that looks like on MRI. We will see examples of how we can call it active disease versus calling it a chronic disease. So disease activity is the major topic here in spondyloarthropathy patients. These patients may or may not have HLA-B27. The MRI has more value in terms of managing these patients as opposed to just having positive HLA-B27. Not all patients with positive HLA-B27 will have SPA, let alone having active SPA. So MRI here is the major test for detecting disease activity, and this is the most important part of our job as radiologists in terms of informing the rheumatologist about the situation on the MRI and whether these patients need active aggressive treatment or not. The MRI protocol, we normally scan these patients on the 3 Tesla scanner. The imaging protocol would include the whole spine and the sacroiliac joints. The spine protocol would include sagittal T1, and the sagittal T1 is good for detecting erosions and also for detecting fatty replacement where the enthesitis is. And also we have sagittal T2 fat saturated sequence for the whole spine that includes the cervical, thoracic, and lumbar spine. And the T2 fat saturated sequence is very useful for detecting the disease activity, which is the osteitis, whether it is related to enthesitis or related to synovitis. The other part of the imaging protocol includes the sacroiliac joints, and our sequences for the sacroiliac joints include axial T2 fat saturated sequence and coronal oblique, and includes T1 and T2 fat saturated sequence. So this is how it looks like. So this is the sagittal, these are the sagittal images of the spine, of the whole spine, which includes the T1 here, T1 cervical, thoracic, lumbar, and T2 fat saturated, again, cervical, thoracic, and lumbar spine. So these are the sagittal images we do. We don't necessarily do axial acquisition of the spine unless we found incidental findings, for example, disc herniation or disc extrusion or tumor. Then we would do axial acquisition for the affected level. And we do not routinely give gadolinium for these patients. And these are the images or the imaging protocol of the sacroiliac joints. Includes the axial T2 fat saturated sequence and the coronal oblique T1 and T2 fat saturated sequence. So these are the 3 sequences that we perform on the sacroiliac joints. And again, we do not give gadolinium routinely for these patients. So we'll start with the first disease entity, which is the ankylosing spondylitis. And ankylosing spondylitis, as I mentioned earlier, is the prototype of spondyloarthropathy. The pathology predominantly affects various areas of the spine and various anatomic locations and various tissues in the spine. The major structure that we are always interested in is the sacroiliac joints. And there is a reason for that, which I will explain later. And then after that is the detection of enthesitis in the spine. And enthesitis is basically an inflammation of the bony attachment of the ligaments. And these ligaments could be the anterior longitudinal ligament, the posterior longitudinal ligament, interspinous and supraspinous ligaments. So all these ligaments may demonstrate enthesitis on MRI scan. So we would need to be very careful with detecting the enthesitis. The other anatomic part of the spine that can be involved with ankylosing spondylitis is obviously the synovitis, which can be seen in the facet joints, in the costovertebral joints, and costotransverse joints. So if you are reporting MRI scan of the spine on patient with spondyloarthropathy, these are the areas that you are going to be looking at. The sacroiliac joints, all the ligaments, and all these joints as well. So this is how you would normally interpret and detect active disease in the spine. Ankylosing spondylitis typically starts at the thoracolumbar spine, then progresses to the lumbosacral spine and the cervical spine. The cervical spine is the last part of the spine that will be affected by ankylosing spondylitis. So what are the imaging features of ankylosing spondylitis? As I mentioned at the beginning, is the sacroiliac joints is normally involved or almost always involved in 100% of these cases. There will be sacroiliac joint involvement. And then we will be also looking for syndesmophytes in the spine. We'll see examples of those, how they look like on imaging. The advanced stages of ankylosing spondylitis, we may see what we call tram track appearance or the dagger sign appearance, which is basically just ossification of the spine of the ligamentous structures around the spine. That would give it the dagger sign appearance or the tram track appearance. The squaring of the vertebrae on radiographs is also a helpful imaging feature. And basically, the squaring of the vertebra happens due to the inflammation, enthesitis, and ossification of the anterior longitudinal ligament. The other imaging features is the enthesitis, which can be demonstrated as shiny corners on radiographs or Romanus lesions on MRI. The advanced stages of ankylosing spondylitis will lead to what we call bamboo spine, which is a very a bad condition for the patients. And because of the early detection and early diagnosis of ankylosing spondylitis, we are seeing fewer and fewer patients with bamboo spine. And that all, the credit goes to the rheumatologists who are very good at early detection of ankylosing spondylitis and early diagnosis and early management. So maybe we just get one of the residents to take a look at this case and interpret the imaging findings.
دكتورة دينا حامد موجودة ويانا؟
نعم أستاذ، صباح الخير.
تفضلي. هلا وصباح الخير.
AP and lateral X-ray of the lumbar spine showing calcification, showing syndesmophytes through the whole spine, and also fine calcifications of the anterior longitudinal ligament and the interspinous ligament, collectively showing the signs of bamboo spine and the dagger sign.
Yeah, perfect. That's actually very, very, very good. I know the sacroiliac joints, we don't normally, and
also,
I personally, I personally,
fusion, complete fusion.
Yeah, that's correct. I personally don't comment always on the sacroiliac spine on a lumbar spine radiograph. I would always suggest having dedicated sacroiliac joint radiographs. But if the sacroiliac joints are obviously very abnormal on the lumbar spine, I do comment on it. So yeah, so you are right. The sacroiliac joints look abnormal. There's periarticular sclerosis and also joint ankylosing. Okay, so the syndesmophytes. So what are these syndesmophytes? Syndesmophytes is basically an inflammatory, it's an inflammatory condition of the annulus fibrosus. And remember, the annulus fibrosus is the outer layer or the ring of the intervertebral disc. So that would lead to the syndesmophytes. So these are the syndesmophytes here, and these syndesmophytes is the annulus fibrosus of the disc. And the syndesmophytes can happen anywhere. They can be anterior, they can be posterior, and they can be lateral as well, because it's the whole annulus fibrosus, is the entire ring of the disc. So they can be circumferential all around. These syndesmophytes are symmetric, and this is a very important thing here, because that distinguishes ankylosing spondylitis from psoriasis and Reiter's. These are symmetric because of the annulus fibrosis involvement in ankylosing spondylitis. Syndesmophytes can also be detected on MRI. You can see these projections. They are vertical projections, and you can see how that actually refers to the annulus fibrosus, that outer layer or outer ring of the disc. So here is the syndesmophyte, the vertical projection. Sometimes they can be subtle on the MRI, but if you look carefully, you may be able to see them on the MRI, and you can describe them and suggest that they correlate with patient symptomatology in terms of inflammatory back pain or HLA-B27. Okay, can we take another resident?
اوكي. دكتورة رجاء عزيز ويانا.
نعم أستاذ، صباح الخير.
صباح الخير، تفضلي دكتور.
Lateral X-ray of the lower, nearly the lumbar area, the lumbosacral area, show a posterior effusion of interspinous ligament with the normal bone density and normal intervertebral disc space. This is posterior interspinous ligament fusion, and this is one sign of ankylosing spondylitis.
Okay. So if I ask you a question, do you mind if you look at this vertebra? How does it look
large,
like?
Yes, large in size, enlargement of the vertebral body size, but normally trabecularly and normal density. فهذا نسميه squaring or squaring of vertebral body shape.
Okay. So what is squaring of the vertebra?
Yes, expansion, يصير expansion of vertebral body expansion.
Okay. Yeah. Okay. So yeah, due to.
Yes.
Sorry, I think
the same lumbar spine an MRI showing nearly نقول هنا settle syndesmophyte early ligamentous anterior ligament calcification. Yes.
Anterior longitudinal ligament. Yeah.
Anterior longitudinal ligament. Yes.
Yes. Remember the anatomy here. Okay. So the anterior longitudinal ligament actually. Yeah, it does not attach to the corner. It's kind of a little bit farther from the corner of the vertebra. So this is where the bony attachment of the anterior longitudinal ligament is. And what we are seeing here is ossification.
Yes, adherent of anterior longitudinal ligament, segmental part to the vertebral body.
Yeah, exactly. So it is actually ossification of the bony attachment of the anterior longitudinal ligament that will give the vertebra the square shape or the flattened anterior cortex, as opposed to the vertebra above, for example, it still has the concavity. You see here, even on MRI, because there is no ossification of the anterior longitudinal ligament. Therefore, the vertebra is still concave, but the vertebra here is more square. So that is the squaring of the vertebra. And it can be sometimes subtle on MRI, and you need to be kind of you need to look very closely in order to detect squaring of the vertebra, and can be one of the earliest features of ankylosing spondylitis. And also, incidentally, here we see fatty infiltration at the corner of the vertebra, which suggests an element of enthesitis as well in the corner of the vertebra. And also in the vertebra here below, we can see features in keeping with Romanus lesion or enthesitis. Okay, bamboo spine, yeah, as you said, the dagger sign and the bamboo spine are the advanced features of ankylosing spondylitis, and luckily we don't see these patients as we used to in the past, and that's because of the early detection and treatment. Bamboo spine happens because of ossification of all the ligaments around the spine that gives it the bamboo spine appearance. Okay, maybe you take another resident.
دكتورة شيماء التميمي.
صباح الخير.
صباح الخير، تفضلي دكتورة.
We have two picture of MRI of mid thoracic vertebra T1 and T2 showing the shiny corner sign, which is high signal intensity in T1, T2 at the superior anterior aspect of the vertebra, with squaring of some vertebra and joint space narrowing, and the center at the center of some vertebra at the T1 sequence showing the central high signal at the end vertebra, which is maybe early sign of Anderson lesion. Collectively, these signs are goes with ankylosing spondylitis.
Yeah, very good. Yeah, so as you said, so I'm just checking here to see if anyone is asking any questions. Yeah, so as you said, there is the Romanus lesion here on the sagittal T2 fat saturated sequence, the edema, and again we see the bony attachment of the anterior longitudinal ligament. And on the T1, we can see these syndesmophytes here. We can see the squaring of the vertebra. We can see the fatty infiltration in the corner of the vertebrae again here, and that all is in keeping with ankylosing spondylitis. You talked about Anderson lesion. We will leave it for now because we will cover it in the next slides. Okay.
But active, this is active.
Yes, this is active disease. Okay, and we will be talking more about the active disease activity and the ASAS criteria in a minute, but definitely this is an active disease because of the osteitis and the edema and the vertebra on the T2 fat saturated sequence. Okay, so Romanus lesion is the corners. These are the corner enthesitis that we see in the vertebrae, as you said, and here on the images that you looked at. So this is how the Romanus lesion. These are the enthesophytes, the vertical projections that affect the annulus fibrosus of the vertebra. So this is active disease. Yes, exactly. All right. Now, the Romanus lesions on the MRI scan will correspond to what we call the shiny corners on the radiographs. So here are the radiographs of this patient with the bony sclerosis of the corner of the vertebra, the syndesmophytes. So remember, the shiny corners and Romanus lesions are the same pathology, but there are two different radiologic features from two different modalities. Okay, sometimes I see residents mixing them up, calling shiny corners on MRI and Romanus lesion on radiographs. So we know the terminology and what terminology belongs to what imaging modality. Again, the enthesitis is not always in the anterior longitudinal ligament or posterior longitudinal ligament. It can also be seen in the interspinous or the supraspinous ligament. So as example, in this patient at T6 vertebral level, we see edema in the interspinous ligament in keeping with enthesitis and again, active disease. Now, the other feature that we see with ankylosing spondylitis in the spine is the synovitis, and the synovitis can be seen in the facet joints, costovertebral and costotransverse joints. And here we have an example of a patient with ankylosing spondylitis, and we see synovitis involving the posterior joints or the facet joints or the costotransverse in this patient, the costotransverse joint at so this must be the facet joint actually, because it's L1, L2 level. So this is facet joint synovitis, and also we see the Romanus lesion of the vertebrae. So always when you're looking at the spine in patients with ankylosing spondylitis, it's not always just the enthesitis, but also look for synovitis in the facet joints or the costotransverse or costovertebral joints. Okay, maybe take another resident.
دكتور حسين عبد الأمير. دكتور حسين ويانا. دكتور حسين عبد الأمير ويانا.
نعم أستاذ.
تفضل عيني. دكتور كمل.
Substance T2 fast saturation sequences of dorsal lumbar spine. Showing there is abnormal signal intensity seen involving the central aspect of the superior and inferior end plate of lower dorsal vertebral bodies, with abnormal signal intensity and then intervening intervertebral disc. The signal intensity is low on T1, high signal intensity on T2, and fast saturation sequences. Most likely in keeping with the admetal changes, with the abnormal signal intensity on the intervening disc. Regarding the shapes of the vertebral bodies looks normal. There is no bridging ossification across the anterior aspect of the vertebral bodies, with normal interspinous and supraspinous ligaments, normal spinal canal and spinal cord signal intensity. Feature most likely in keeping with the Anderson lesion and abnormal signal intensity within the intervertebral disc and the adjacent end plates.
Yeah, perfect. Yeah, exactly. That's very good, actually. Yeah, it's an Anderson lesion involving the intervertebral disc. And what we see here is the endoplate edema. What is actually, how, may I ask a question? How can you differentiate this Anderson lesion from discitis?
I think we need to, on these only sequences, we may need to do IV contrast to look for enhancement of the intervertebral disc.
With gadolinium, I think both of them will enhance. Anderson lesion and discitis will both enhance. But without gadolinium, just on these images, what can you see on these images that may be helpful to you to, with great degree of certainty?
Intensity of the intervertebral disc may become more high signal intensity on T2.
Similunar shape.
Okay, so the major imaging feature that would help you differentiate between Anderson lesion and discitis is the disc height.
Yeah.
Normally with discitis, what do we expect to see?
In obliteration, decrease in the disc height.
Yes, exactly. Yeah, so you will lose the disc space. There is loss of disc height. That
Yes.
is the most worrisome feature of discitis, is the loss of disc height, whether it is on radiograph or MRI or CT. Whenever you see loss of disc height, is always worrisome for discitis. But Anderson lesion, actually, the disc height is maintained. So that's how you can tell them apart with a great degree of certainty. Okay, so this would be a case of Anderson lesion. And there are two types of Anderson lesion. An Anderson lesion is an inflammatory change that involves the discovertebral joint. Type 1, type A, the one that you just looked at here, that's type A. And type A is inflammatory. And that happens in the first 9 years of the disease. It's a stable condition, and it happens because of the herniation of the disc into the endoplate. Now, you need to differentiate this from type B, and well, let's take another resident. Hello?
نعم أستاذ هارون وياك عيني.
Okay, sorry, I just thought we lost the connection.
Okay. دكتورة تراث موجودة؟ تراث. دكتور أحمد فايز.
نعم أستاذ، السلام عليكم.
عليكم السلام. هلا دكتور أحمد، تفضل.
Both sagittal, both lateral AB of dorsal spine and sagittal CT scan of dorsal spine showing there's horizontal oriented minimally displaced fracture seen at the level of discovertebral junction of lower dorsal vertebra involving both the anterior and posterior element. The whole spine show complete ankylosing with the narrowing of the intervening disc space, bridging multi-level bridging syndesmophyte. Feature goes with the horizontal insufficiency fracture or choke stick fracture in the setting of ankylosing spondylitis.
Yes, perfect. Yeah, choke stick fracture. So we go back to type B Anderson lesion. And type B Anderson lesion is what we call the non-inflammatory type, and it is a delayed manifestation of the disease. It's unstable because it's a fracture. It's a fracture that happens through the disc and sometimes leads to pseudoarthrosis. And this is a surgical case. Most of these patients will end up having spinal fusion by orthopedics in order to stabilize the spine, because the spine is very unstable here. So this is how Anderson lesion type B looks like. And on MRI scan, again, Anderson lesion type B, and we see that fracture going through the disc and the posterior element of the spine. So this is type B Anderson lesion. So remember, type B Anderson lesion is not inflammatory, is more mechanical, is more fracture, and it is unstable and requires surgical fusion. And that's the choke stick fracture. Okay, take another resident.
Yes. دكتورة سارة عدي.
نعم، صباح الخير.
صباح الخير، تفضلي سارة.
Magnified view of both sacroiliac joint, plain radiograph, showing there is irregularity of both sacroiliac joint, more of the right joint with sclerosis, subchondral sclerosis, and decreased joint space, more of the right, and involve the lower part. Picture of asymmetric sacroiliitis.
Yeah, so this is sacroiliitis. So sacroiliitis is the major component of ankylosing spondylitis. And most of the times we see it radiographically. And MRI can be ordered. And sometimes I suggest it when I look at the radiographs and I see changes on the radiograph that would be very concerning for sacroiliitis. I would be suggesting an MRI scan in my report because MRI is very helpful and it is the mainstay for the as far as the New York criteria for ankylosing spondylitis is concerned. So it can happen, sacroiliitis can happen in ankylosing spondylitis in about 80% of them or more in the first 9 years of the disease. So you would expect to see sacroiliitis in patients with ankylosing spondylitis at some stage in their life or in their disease progress. So it is really important that we understand how the ASAS criteria or classification for SPA is designed. So normally what happens is you get patients who are under the age of 45 years old who present with inflammatory back pain for more than 3 months. So this is your typical scenario here. So what do? We have a patient who is under the age of 45 with inflammatory back pain for more than 3 months. There are two pathways to address this situation for these patients. So you either go down the imaging pathway or the HLA-B27 pathway. If you go down the imaging pathway using radiographs and MRI, and if the imaging detected sacroiliitis, then you only need one clinical feature to support the diagnosis. So any one of these here, even elevated CRP, is considered one supporting feature. So any one of these supporting features, you need one of them combined with sacroiliitis to call it SPA. Now, the same patient could go down the HLA-B27 pathway, but if you go down the HLA-B27 pathway, you need 2 or more of these supporting features. And the reason why it's designed like that is because imaging detection of sacroiliitis has more value and more important than just having positive HLA-B27. So you can see that actually MRI is more valid than HLA-B27, because here you only need one feature, but here you need 2 features. If MRI is positive for sacroiliitis, the specificity is very high, is more than 97% for sacroiliitis. And that's the reason why, if the MRI scan is positive, then you only need one supporting feature to go with it. So understanding the ASAS criteria for labeling patients with SPA is very important, because at the end of the day, we really need to use the imaging tools we have for the accurate diagnosis, and we don't want to call all patients or we miss sacroiliitis patients. So it's very important that we understand how these patients are managed. Radiographic detection of sacroiliitis, there's a grading system for it. Obviously, grade 0 is when the sacroiliac joints are normal, grade 1 when the features are equivocal, and grade 2 when there are minimal features, for example, just sclerosis or just joint space widening, but no features to go with erosions. And if you saw erosions, then that would be under grade 3. So the grade 3 is unequivocal. The sacroiliitis changes are very obvious on the radiographs. You see erosions, you see sclerosis, you see pseudo widening, or even narrowing in the advanced stages, and the ankylosing of the joint as well. Grade 4 is when there is complete fusion and complete ankylosing of the sacroiliac joints. So here we'll see examples of that. So this is grade 3 when the features are unequivocal. So there is erosions, there is on both sides, on the iliac side of the sacroiliac joints, and there is subchondral sclerosis. You see that both on radiographs and on CT. So this is a grade 3 sacroiliitis. And sometimes what we call pseudo widening. Does anyone know what pseudo widening is? Yeah, so pseudo widening is, sorry?
I think when there is an extensive erosion involving the joint space, so it will give us an impression of there is widening in the joint space, but actually there is no widening. It is the erosions, the extensive erosions that cause this.
Yes, exactly. Yeah, that's correct. So it's the erosions, that diffuse erosions of the sacroiliac joints actually that would lead to the pseudo widening of the joints. Grade 4 radiographic, grade 4 is when there is complete ankylosing of the sacroiliac joints. That's a very advanced stage. That's the end stage of the ankylosing spondylitis, and we see the darker sign here as well. So this patient either has been missed, never been treated, never been investigated, and presented with advanced stage of ankylosing spondylitis. Again, the same features that we just described on radiographs, we could also see them on CT. So, for example, a grade 3 with sclerosis and erosions of the sacroiliac joints, and a grade 4 with complete fusion or partial fusion of the sacroiliac joints. Come back to MRI and the sacroiliac joints. So remember what we talked about the ASAS criteria, and we said when there is positive MRI for sacroiliitis, you only need one supporting clinical feature, because MRI is considered the gold standard for active SBA. So this is what you really need to remember. The MRI also can be problem-solving tool for equivocal cases where we're not really sure if we are dealing with SBA or we're dealing with other situations such as tumor or infection. So it can be problem-solving here. MRI appearances such as osteitis or synovitis or capsulitis can quite predate the radiographic features of sacroiliitis. And also, even if the patients have been diagnosed, have been treated, they would come back for MRI for a follow-up in case their disease activity came back, even if they have been treated. Because what happens with these patients, the rheumatologist would treat them with non-steroidal anti-inflammatory medication, and then they will move on with more aggressive treatment. So if they started with simple management therapy, and then patient presented back with disease activity, then we do the MRI scan as a follow-up on these patients to detect disease activity. If the disease remained active despite their treatment, then they move on to more aggressive treatments such as the biologic or disease-modifying drugs. And they don't routinely give patients biologics or disease-modifying drugs, because these drugs actually have severe side effects for patients. So they really need the MRI before they start the biologics or the disease-modifying drugs. So how can we describe MRI as positive? So what is the criteria for MRI positivity? And we go again back to the ASA's criteria for diagnosing active disease. It is basically identifying active sacroiliitis in the joints, in the sacroiliac joints. Now, whether or not you have inflammatory changes in the spine, such as the squaring of the vertebra, the Romanus lesions, the Anderson lesion, and all of these are considered supportive for the diagnosis of SBA. All of those are considered supportive. The major diagnosis for this patient would be the active sacroiliitis, regardless of the changes that you see in the spine. So the MRI criteria, just for us to be consistent, so if I looked at MRI scan of the sacroiliac joint and I called it active sacroiliitis, then I would expect almost all the other radiologists to also call it active sacroiliitis. So how can we achieve that high level of consistency with the inter-observer or inter-reader agreement? If we want to achieve a high level of inter-reader agreement, then we should stick to these rules, 1, 2, 3. These are the rules. If we follow these rules, then you and I and everyone, when we looked at the sacroiliac joint, we called it positive, and everyone would call it positive. So the first thing is actually you should detect osteitis or the edema around the sacroiliac joints, and you detect that on either T2 fat saturated sequence or on stir sequence. Secondly, that edema should be either in the periarticular or subchondral region of the bone. Okay. Criterion number 3, that if you saw 2 or more areas of bone marrow edema, on the same image, that's considered positive. But if you only saw one area of edema, then it should be more than one image, like 2 consecutive images or more. So it's either 2 areas of edema on one image or 1 area of edema on 2 images or more. So if we follow these rules, these criteria here, we will have a high level of inter-reader agreement. We will all call it active disease. And again, this is very important because if we want to achieve high level of specificity for the MRI, then we should follow the criteria. Then we call patients positive when they are positive, and we call them negative when they are negative, and then we avoid the false positive and the false negative. So how does it look like on MRI? Active sacroiliitis, this is how it looks like. So this is the axial T2 fat saturated, this is the coronal T1, this is the coronal T2 fat saturated sequence, and we see this area of osteitis. If we go back to this, the 3 criteria we just saw on the previous slide, this is the subchondral periarticular osteitis. We see multiple areas of osteitis and edema on one image. So that would meet the criteria for active disease. And again, here, the same thing. So if, when you look at this patient 100% meets the criteria for active sacroiliitis. So this is typical case or typical example of active disease. So osteitis is the major feature of disease activity. Now we may ask question, what about capsulitis, synovitis, enthesitis, erosions, sclerosis, and fatty replacement? These are not considered disease activity. They have absolutely no influence. They are not considered as part of positive MRI for disease activity. They may be considered as chronic sacroiliitis or chronic disease, but they are not considered as part of positive MRI for active disease. The only feature that is considered as useful for calling it active disease is the high signal intensity, the edema, or the osteitis. That's the only imaging feature on MRI. The rest is not considered positive. So, and again, it goes back to the specificity of that bone marrow edema. The bone marrow edema has higher specificity than all the other ones, the capsulitis, synovitis, and enthesitis. The only imaging feature that has high specificity is the bone marrow edema. Studies have looked at the disease distribution. Is the disease more in the sacroiliac joints than the spine, or vice versa? A study by Braun et al. Found that 27% of patients with spondyloarthropathy may have disease in the spine with normal sacroiliac joints. So this is actually very important. And this is why we image the whole spine as well as the sacroiliac joints in patients with spondyloarthropathy because of that, because 27% of these patients may have disease in the spine without the sacroiliac joints. And also another study by Bennett et al. Found that 20% of thoracic lesions may be missed if we did not scan the spine. If we just scan the sacroiliac joints for all these patients, we will be missing 20% of thoracic lesions. So there are 3 types for sacroiliitis. Remember, it's only this one that's considered active, type 1, the edema, which is seen on STER or T2 fat saturated sequence. Sclerosis and fatty replacement, they are not considered active disease. They're considered chronic disease. They don't require treatment. They don't require biologic therapy. It's only this one that is considered active and requires biologic therapy. So this is type 1. We see periarticular osseous edema around the sacroiliac joints. This is type 2, where we see sclerosis, the dark areas around the sacroiliac joints. And this is type 3, where there is a fusion of the sacroiliac joints and fatty infiltration around the joints. So these are the three types. What is the mimicker, or the greatest mimicker of sacroiliitis is osteitis condensans eili. So just be aware of this entity. This entity happens in mainly women with multiple pregnancies, and you see the sclerosis around the iliac side of the sacroiliac joints. This is not inflammatory. Patterns of sacroiliitis, so the sacroiliac joint involvement could be bilateral symmetric. We see it with enteropathic and ankylosing spondylitis. Bilateral asymmetric, you see it more with psoriasis, Reiter's, and Behçet disease. Unilateral is always worrisome for infection or SAPHO. So this is the pattern of sacroiliac joint involvement. Each pattern has different list of differential diagnoses. So always be mindful when you are describing sacroiliitis, and just be more descriptive and assess whether that's symmetric, asymmetric, or unilateral. Ankylosing spondylitis also can involve the appendicular skeleton, and when you see that, you see uniform joint space narrowing. And most commonly you see it in the lower limbs, in the knees and the hips. And it's when you have a pelvic radiograph like this and you see changes in the sacroiliac joints in keeping with chronic sacroiliitis, look for the uniform joint space narrowing. If there is uniform joint space narrowing, it means there's also involvement of the appendicular skeleton. In this more advanced case, we see fusion of the sacroiliac joints and fusion of the hip joints as well. So that's part of the appendicular skeleton involvement in ankylosing spondylitis. Okay, I have another resident.
دكتورة هويدة إذا موجودة.
نعم أستاذ، صباح الخير.
صباح الخير.
X-ray of the lumbar spine, showing area of ossification on the left side of the vertebra. It mostly goes with parasyndesmophyte, and it's mostly a case of psoriatic arthritis.
Yes, very good. Yeah, so move on now. We finished with ankylosing spondylitis. We move on to psoriasis. So the characteristic feature of psoriasis and Reiter's, by the way, is what we call the paravertebral ossification, which is these bulky and chunky ossifications that we see around the spine. So remember how, we'll see a comparison in a minute. So this is the major characteristic feature of psoriasis and Reiter's, is the paravertebral ossification. You may also see syndesmophytes, but they are non-marginal, not like ankylosing spondylitis. With psoriasis, there is more predilection for the cervical spine involvement. Remember, when we talked about ankylosing spondylitis, we said the disease would involve the thoracolumbar spine, then lumbosacral spine, and the last part to be involved is the cervical spine. However, in psoriasis, the first part to be involved is the cervical spine. So it's completely the opposite direction of ankylosing spondylitis. And also we see bilateral asymmetric sacroiliitis, and involvement of the sacroiliac joints is less severe than ankylosing spondylitis. So this is the paravertebral ossification we just talked about, and this is how we can compare ankylosing spondylitis with these fine, delicate syndesmophytes compared with these chunky, massive paravertebral ossifications that we see with psoriasis and Reiter's. And as I mentioned, the cervical spine is the first one to be involved with psoriasis. You see the anterior syndesmophytes here, and you see fusion of the facet joints at the back. So this is typical appearance. If you saw a radiograph like that, and the rest of the spine, the thoracic and lumbar spine, look relatively normal, then your differential diagnosis should be more leaning towards psoriasis as opposed to ankylosing spondylitis. So the involvement of the sacroiliac joints is different to ankylosing spondylitis. Here we get bilateral asymmetrical involvement. Again, we see the erosions on the iliac side of the sacroiliac joints. We see pseudo-widening because of these erosions. And sacroiliac joint involvement occurs in about 10 to 25% of patients with moderate to severe psoriasis. And this is how it looks like on radiographs. There is asymmetric sacroiliac joint involvement, and we see the same thing on CT. There's more diffuse erosions on the left side, fewer erosions on the right side, and this patient is more aggressive involvement on the left than on the right. So this is bilateral but asymmetric sacroiliitis, which goes with psoriasis. Okay, move on to another case.
Okay.
We have another resident.
دكتورة صابرين. دكتورة صابرين. دكتورة حنين. دكتور سيزار.
نعم أستاذ صباح الخير.
تفضل صباح.
Okay, X-ray of the fingers, frontal view showing the tuft or the distal phalanx, irregularity and erosion. More on the anterior or the tuft region. Also, the distal interphalangeal shows some irregularity and sclerosis with marginal osteophytes. So all features going also with psoriasis, psoriatic finger.
Yeah, so do you know what the term is, the terminology for this fluffy appearance of the tuft, and also for these protrusions here?
Sorry.
Yeah, okay, that's fine. So we move on to writers. So this is writers, and writers is characteristic. Again, it's a disease that involves, although I know I showed you fingers, but we will come to this in a minute. So it is the disease that has the strongest association with HLA-B27. It is almost always a disease of the male patients. It never occurs in women. There is involvement of the spine, just like how psoriasis look like. There is association with infections, urogenital and enteric infections. The clinical triad of writers is arthritis, urethritis, and conjunctivitis. So when patients present with this kind of clinical situation and back pain, inflammatory back pain, then we would be more concerned about writers than ankylosing spondylitis, for example. So this is normally typically the background of these patients, the writers' patients. And the involvement of the spine, again, we will have the chunky paravertebral ossifications. We will see the asymmetric syndesmophytes, similar to psoriasis, and we will see sparing of the cervical spine. This is completely in contrast with psoriasis. Remember, we said with psoriasis, the first thing to be involved is the cervical spine. Writers tend to be more distal than proximal. Even in the appendicular skeleton, there's more involvement of the lower limb than the upper limbs. So this is how writers looks like. Again, we see these paravertebral ossifications around the spine and here as well. So this is the typical appearance of writers. Involvement of the sacroiliac joints, bilateral asymmetric, just like psoriasis. So we see more aggressive involvement on the left than on the right on radiographs and CT, and that goes with writers. And again, on MRI, we see the same thing, more aggressive involvement on the right side than on the left side. That goes with writers. Okay, come back to your image. So that's called periosteitis, and this is characteristic appearance of patients with writers. There is hypertrophic periosteitis and bone formation. So this is the typical appearance of hyperostosis periosteitis that you see in these patients. They form more bone in the periosteum. So if you had a patient with features on radiographs that looked like that, periosteitis and hyperostosis of the digits and the phalanges, and they presented with inflammatory back pain, it would be more likely to be writers. Okay, take another case.
اوكي دكتورة نور عباس.
صباح الخير.
صباح الخير تفضلي.
APX ray with the sagittal CT scan showing ankylosing of thoracic vertebrae with also some fracture. Ankylosing of anterior longitudinal ligament going with the dish.
Yes, fantastic. Yeah, dish. So where's the paravertebral ossification?
Anterior longitudinal ligament.
Here on this radiogram. Is it more on the right or on the left?
More on the right side.
Why is it more on the right than on the left?
يعني
Heart pulsation.
Because of the aorta.
Yeah, aortic pulsation. Yeah, we're getting lots of responses here. Okay, so aortic pulsation, because you remember thoracic aorta comes down here, yeah?
On the left side.
Yeah, on the left side. So that's why you get more
on the right side.
Also. Okay, so dish. So I included dish here as SPA mimicker. Okay, sometimes people get this confused and they call it SPA, but it's actually not SPA. So what is dish? Diffuse idiopathic skeletal hyperostosis is bulky flowing ossification of the anterior longitudinal ligament, as you said. It is on the right side of the thoracic aorta due to aortic pulsation. And it is characteristically preserves the disc. So that's how you differentiate dish from, for example, degenerate disc disease. Because degenerate disc disease, you will see disc degeneration and disc height loss. But with disc, there is actually a preservation. If we go back to your case, the disc height is preserved. So this is not a degenerate spine. This is diffuse idiopathic skeletal hyperostosis. Most of the times we see it incidentally, whether you're reporting a chest x-ray or you're reporting CT scan of the chest. But sometimes patients with dish may have OPLL, and this is ossification of the posterior longitudinal ligament. And when patients develop OPLL, they may have myelopathy because of the spinal cord compression. So how we differentiate dish from SPA? Dish is the paravertebral ossification. They are normally right-sided for neighboring vertebrae. No sacroiliac joint involvement and no syndesmophytes. However, with SPA, we will see the syndesmophytes. We will see more than 4 vertebrae. And we will see characteristically there is involvement of the sacroiliac joints. And we will see the radiographic features of the spine involvement, which is the shiny corners, romanus lesions, squaring of the vertebrae, and all the other features. So this is how we differentiate dish from SPA. Okay, so here we have 2 examples. Here we have patient with dish. Here we have patient with ankylosing spondylitis. We see the syndesmophytes here, squaring of the vertebrae. But here we see the paravertebral ossification and the dish. Degenerate joint disease, I'm sure you are very familiar with this. I just included it because just to remember, the osteophytes here with disc degeneration are horizontal. However, with SPA, the syndesmophytes are vertical. Also with psoriasis and Reiter's, the paravertebral ossification is vertical, but with degeneration is always horizontal osteophytes. And sometimes you get spine failure by development of deformities and scoliosis. This is normally an older age disease, older age patient disease. Remember with SPA, most of these patients are younger than the age of 45. So that's how we differentiate sometimes SPA from disc degeneration. Here we have degenerate spine. I'm sure you've seen thousands of these. Degenerate disc disease, facet joint degeneration, segmental instability with anterolisthesis, scoliosis, and horizontal osteophytes. So this is typical degenerative disease. And degenerative disease on the MRI, again, modic end plate changes, loss of disc height. Remember, with SPA, there is a preservation of the disc height. So this is typical degenerative joint disease. This is not Anderson lesion. Remember, when we looked at Anderson lesion type A, we saw preservation of the disc height. But with modic type 1, degenerative disc disease, there is loss of disc height here. Sacroiliac joint also can be confusing sometimes. How do we call it sacroiliitis versus, for example, degenerate sacroiliac joint? And again, use the age. With degeneration, normally these are older patients. There is no ankylosing, there is no erosions, unless it is erosive osteoarthritis. You don't see the features in the spine, such as in dysmorphites. And if you have appendicular skeleton radiographs in these osteoarthritis group of patients, you will see asymmetric joint space narrowing. But in patients with SPA, they are younger than 45, you see the enclosing of the joints, you see this in dysmorphites. And if you have appendicular radiographs for these patients, the joint space narrowing is uniform, as opposed to asymmetric in degenerative joint disease. Here we have two examples, SPA on the right, the degenerative joint disease with osteophyte on the left. And remember, sometimes the most confusing part in osteoarthritis of the sacroiliac joints, it can be erosive. So that's when you might need further imaging such as MRI or clinical features or HLA-B27. Joint infection is unilateral. The sacroiliitis, the septic sacroiliitis is unilateral. This is very worrisome. We see joint effusion, we see periarticular edema, we see psoas abscess, we see soft tissue edema. Normally, when I see this, I call the referring physician right away because this patient needs hospitalization and intravenous antibiotics. These are high-risk patients because they are either IV drug users or HIV patients, that high risk of septic sacroiliitis. So in conclusion, we talked about all the techniques, all the imaging modalities for assessing patients with inflammatory spine. We mentioned that active SPA is something that we need to emphasize, and we need to follow the criteria for active disease and MRI positivity criteria according to the AS criteria. We normally image the spine as well as the sacroiliac joints because, as we mentioned earlier, studies have shown that 27% of these patients may have disease in the spine with completely normal sacroiliac joints. And always remember that there are mimickers for SPA, such as osteitis condensa eili and DISH, and how can we differentiate those and radiologically? And in case of there is any overlap or uncertainty about the diagnosis, always refer to the history and all the lab tests as well. Okay, so that's the end of the talk.